So like I mentioned, Marilyn Sampillo is going to be joining us in December, but she got double booked for today. So I put together this set of slides about syndemics and severe mental illness. And syndemics is something that I've been reading about maybe for the last year or so. So I thought it'd be a nice way to introduce the concept, and it ties into some of the other topics that we've had. So as we get into syndemics, I wanted to start out by first talking about the vital conditions for well-being. And this is a talk that I'll do in more depth in January, but some examples of vital conditions would be like food, humane housing, but like vital signs, vital conditions help us to understand what's going on within our community and the world around us. And the idea is that vital conditions are properties of places and institutions that we need in order to reach our full potential. So if everyone has access and is assured, access to these vital conditions, then everyone thrives. Entire communities and populations thrive. These things tend to safeguard communities from avoidable adversity and urgent needs. But if we neglect or deny any of the vital conditions for any one part of our society, serious adversity can accumulate. Things such as illness, injury, poverty, addiction, loneliness, crime. And if left unchecked, this can become this entrenched adversity can really create a suffering spiral throughout communities. So syndemics, which you can kind of think of as synergistic epidemics, emerge when two or more health conditions co-occur in the environment with also aggravated adversity, and they interact synergistically to yield worse health outcomes than each affliction or disease state would in and of itself. So they work in a negative feedback loop among comorbidities and upstream factors that are often overlooked in clinical care, things like social, economic, political, and structural determinants of health. A unique feature of a syndemic approach to understanding disease is that it allows us to understand various disease states, the way in which they cluster together, and there's an emphasis on the situation and the circumstances that people live within. So syndemics really rely on context. It's a concept that was introduced in the 1990s by medical anthropologist Merrill Singer. And his notion was, he was trying to describe the interaction between substance use disorder, violence, and AIDS. And he was looking at this through a health crisis in Hartford, Connecticut. But while he was investigating HIV prevention and drug users, his research ended up taking this weird turn into looking at structural risk factors, lack of housing, poverty, social issues like stigma and support systems, and how all of those reinforce the disease burden. So any changes in political or economic conditions and the related breakdown in protective health measures really impact and add on to the detrimental health effects for specific populations. Now you could look at this in the context of chronic disease and mental health. The dominant clinical paradigm in I wouldn't say within our little world, because integrated care does tend to look at this differently, but for many years has been to look at things like diet, exercise, medication adherence, without much context to the structural factors that may get in the way. We know that non-communicable diseases have very common risk factors, which result in escalation of comorbidities, particularly in marginalized populations. So a syndemic approach looks not only at the clustering of the diseases, but also the social conditions that perpetuate social inequity. There's ample evidence to show that there's a higher risk of depression with increasing levels of comorbidity, and with more medical illness and depression, that turns into a higher mortality rate and more functional impairment. So syndemics really emphasizes that they emphasize the adverse effects on depression and chronic illness, which leads to poor care, excess disability, increased mortality, all of which is exacerbated by social inequity, particularly in the context of COVID-19. So this was a bit of a complicated chart that I tried to take a picture of, but then break down a little bit. So in syndemics, we have to understand that there first is a biological interaction between the two diseases. And you can get access, the articles that I used, I believe were all open access or things that we could help you get access to. And you should be able to find those links in the slides after Jamie shares them after today. So we can understand the circumstances, we can describe what circumstances the diseases interact. So socioeconomic factors like poverty, migration, discrimination, exposure to chronic and acute trauma, including violence, all of those are associated with mental health, diabetes, or both. Anthropological research also shows us that there's unique social factors that cluster with syndemic diseases. Specifically, in the example that they're using in this article, is depression and diabetes within specific populations and social contexts, which really exacerbate suffering. And then all of that actually interacts then with the health system in which the diseases are treated, and how the diseases are treated, it really influences how the disease progresses and the potential suffering and greater impact of the diseases themselves. And so with the health system, we're looking at detection of the disease, types of treatment that are offered, whether it's pharmacological therapies, collaborative care versus siloed care, psychological interventions, behavioral interventions, things that address social determinants. And when we look at it from a syndemic approach, the idea is that social policies should also address some common risk factors for all of these. So if we're looking at depression and diabetes, social policies should be, and the health system should be looking at diet and exercise constraints, financial insecurity, interpersonal violence, and social cohesion. That's kind of the bigger overview, which is exactly why I tried to split it up into little sections. So looking at this in the case of depression and diabetes, we know that depression contributes to inflammation and glucose intolerance. That inflammation then contributes potentially to depression. And you see this negative biofeedback loop that underscores the importance of recognizing all of it. Patients diagnosed with diabetes could be provided maybe health promotion interventions to reduce the risk of depression. Patients with both conditions could be enrolled in collaborative care. So we see that not only poverty, but subjugation, being a marginalized population influences psychological distress, which also has an impact on diabetes, but internalized emotion related to past abuses, feelings of grief and longing, possibly related to family displacement, all of that influences illness. Untreated depression is a risk factor for diabetes through behavioral pathways. And psychological treatments of depression, such as CBT, can actually and have been shown to improve glycemic control. They also reduce risk factors for people who are with depression from developing diabetes in general. So health systems factors that could be interacting and to actually influence all of this, all of the things that we said, including screening and prevention, but also recognizing and addressing the economic burden of gaining access to care. And when you look at it from specific populations, so here's a couple of examples. Older African Americans having a disproportionate burden of depressive symptoms and in the presence of diabetes, a greater risk of dementia, loss of independence. They gave an example in this article about a misdiagnosis of grief for a woman. They misdiagnosed her grief as psychosis, and this resulted in her being admitted to a psychiatric hospital, rapid weight gain due to the medications they gave her, and then the onset of diabetes. And they also discussed Mexican women in Chicago, Mexican immigrant women in Chicago. The Syndemic Approach revealed how violence, immigration, and abuse clustered with depression and diabetes. So being a woman and an immigrant or migrant led to certain patterns of structural violence, immigration-related stress, interpersonal abuse, and marginalization within the healthcare system, all of which then exacerbated both the depression and the diabetes. And I wanted to take a look at it in terms of schizophrenia. While there is much less research on this, I've tried to piece together what I could to try to view it from a syndemic approach. And I feel like this is something that probably deserves far more research. We know that the stress vulnerability model assumes that there are genetic factors that make some people more vulnerable to environmental stress, and that we have to mitigate stress in order to reduce the possibility of symptoms. There is some evidence that familial clustering of psychotic disorders is greater if you actually measure it in terms of risky environments. So suggesting that it's not just a genetic influence, but a gene/environment interaction. This tends to be higher in urban environments amongst minority groups. Although studies from 4 countries have shown that if you look at the ethnic density in a community, the higher the percentage of that ethnicity within the community, the lower the risk of psychosis, which really shows that if you have more social cohesion, and that leads to less social exclusion, and there seems to be a correlation there with less, less risk of psychosis. Also, anything, any kind of cannabis or drug abuse can work within all of these factors. Developmental trauma. The bigger picture is that the adverse effects of social, economic, and societal factors, along with stigma, all can constitute a form of structural violence, which impairs access to psychiatric and social services, amplifies the effects of schizophrenia in the lives of people who are diagnosed with it and their families. And that those are really the areas of need when we're looking at good treatment. And so I guess in terms of how we could better treat persons with schizophrenia, I'd be looking at how do we really understand schizophrenia from a syndemic approach. Looking at the interactions between genetic risk, social environment, really coming up with a more comprehensive biopsychosocial approach to the illness and to treatment. Also, just really always emphasizing the need for protections for people with mental illness as a vulnerable category, and any kind of legislative measures, so parity within the healthcare system and with insurance. An ongoing study to figure out what are the things here that we might be able to actually make some kind of impact or change with. So in summary, there's high comorbidity with chronic diseases, adverse structural factors, all combined with stigma of mental illness equals structural violence. People who face increasing structural vulnerability or increased risk of disease, and a syndemic approach is really needed to better understand all the factors for both people with severe mental illness, schizophrenia, bipolar disorder, depression. Depression is certainly the one that's been looked at most, and substance use disorder. But all of those, we really need the syndemic approach to look at all of the mental conditions and the comorbid medical conditions, and if we're going to create some real change. And we will do a little bit more further exploration on structural competency on December 4th in a didactic with myself and Dr. Boltry. And here are my references.